Good morning, good afternoon, everyone. This is Michelle Takemoto. We're going to be introducing ourselves and describing ourselves in the interest of accessibility. So I am a middle-aged woman with dark curly hair, wearing a sleeveless dress that's sort of a lightish red color. So again, I'm Michelle Takemoto. I am the project coordinator for MGPN, and I work for both the Hawaii Department of Health and the Western States Regional Genetics Network. So today's discussion is going to be about diversity and advocacy in genomic medicine. I think all GCs are used to the concept of advocating for our patients in individual clinic settings, but perhaps not so much in the broader social context. Next slide. I'm not sure where we are. Oh, Afifa? Oh, there we go.
Yes. It's a little delayed. Sorry about that.
Oh, okay, no problem. So this is our agenda for today. So I'll be talking about the overview of diversity and health equity concepts, and then our panelists will each have a turn to speak, and then we'll have a moderated discussion for the last half and time for Q&A. So to start with, I think with all of the discussions about racism in medicine over the last year and a half during the pandemic and overall access to medical services for underserved populations, I think for probably a lot of people in the audience, they've heard some of these concepts before. But so there's a big difference between equality and equity. So equality of access, sorry, there's a helicopter behind me. So equality of access would mean all the services are the same, and it's up to the patients to be aware of what services are available, navigate the system. Medical providers tell everyone the same thing. But the reality of the situation is that for populations who are living in poverty, who don't live near medical services, particularly genetic services, have transportation issues, who live in rural areas. I mean, there's so many different challenges for different populations that, that equality can be a barrier to services. So for different populations like racial and ethnic minorities, LGBTQIA+ populations, that can be a major barrier. Equality can be a major barrier to services. So with equity, we take into account what information is accessible to different populations and communities. And then there are the issue of biases against certain communities where providers may not feel comfortable with certain patients, or they may not share the same information with their patients, with certain patients that they would with others. And implicit biases that the providers are not even aware that they carry can also be a barrier. Let's see, so let's move on to our first panelists. So,
I'm so sorry. Whoops, I skipped one. Back up.
Oh, there we go. So we have Kim Zachowski, and we also have Tala Barrow, who did a wonderful presentation, a wonderful webinar recently. So I would highly recommend that everyone in the audience go back and watch that one too. That's on the NSGC website. And Tala is in clinical practice at Massachusetts General Brigham and Women's. And she's a queer Palestinian community organizer. Oh, okay. Kim's going to introduce herself. Sorry, I will let. Yeah. Okay, go ahead.
can introduce myself as well too.
Okay, sorry.
That's okay. So my name is Tala. I use she, they pronouns. I am a person in their late 20s. I do have short wavy brown hair. I'm of Palestinian descent, and I'm currently wearing a salmon colored shirt with a green sweater. And then my background is my living room, where you can see my couch and some artwork. And as Michelle said, I'm a clinical genetic counselor in the general adult clinic and also a project manager at Mass General Brigham. They actually recently changed their name, Michelle, from Brigham and Women's to Mass General Brigham. And I also am an educator at the IHP genetic counseling program in Boston. And additionally, I'm just a queer Palestinian community organizer, so doing a lot of activism within the Boston area.
Hi, everyone. My name is Kim Zachowski. I use she, her pronouns. I am in my late 20s. I'm sitting in my living room and there's a big window behind me. I have shoulder length, brown and blonde hair, and I am Vietnamese and white. And thank you for having us today. Me and Tala are here to kind of represent queer issues. So I graduated from Stanford's genetic counseling program a couple years back and now work as a cancer genetic counselor and clinical researcher at Boston Medical Center. And I also teach at Boston University's genetic counseling program.
So we wanted to start by just highlighting some of the inequities in care for LGBTQIA folks. So, starting with lack of acceptance, there have been lots of studies that have shown that LGBTQIA, which I'll, shorthand call queer for this webinar, just to, have that shorthand. But queer folks have shown higher rates of discrimination within healthcare. 20% of trans patients also have been actually turned away from their providers. There's misgendering within healthcare. And then there's this nefarious pathologization of intersex, trans, and larger LGBT identities. So you can see this specifically come up when we think about, intersex newborn surgeries and the pathologization around that and how it's framed as something that needs to be done, even though it's not medically necessary. And similarly, you can see this happening with a lot of the genetic research looking for a gay gene or a trans gene and how, these identities are being pathologized. Another big disparity is lack of access and, specifically health insurance access. So there's limited access maybe because of different family dynamics. So they're not able to get onto family healthcare plans, or they're not able to get on their spouse's healthcare plan due to different restrictions around that. There's often limited insurance coverage for gender affirmation, surgeries, and hormones. And then another big lack of access here is that insurance coverage is often dependent on the sex. So if somebody needs screening, but they are, their insurance is under a sex that people don't typically think screening is needed under that sex, then it may not be covered. So for example, if it's someone who is a trans man, their insurance may be listed as male, but they may still need to get some chest screening. And so in those cases, insurance may not cover it. And then finally, there is a big lack of research and education. So 33 to 50% of gender diverse patients actually reported needing to educate their providers on their own healthcare. So they needed to advocate for themselves and know the stuff for themselves. And then additionally, in a study I did in 2019, 24% of GCs reported having trans healthcare training, which means that, over 75 did not. And then, one of the biggest lack of research in this area is that there's limited data on the healthcare needs of LGBT populations. And one of the big ones is that we don't have a lot of data on how gender affirmation therapies can affect cancer risk or cardiac health. So for example, if someone, has a BRCA mutation, how does this play into them taking different hormone therapies and things like that. So there's a lack of data there and information, which shows that people aren't doing research in this area, which is a large inequity for LGBTQIA folks.
So we wanted to talk a little bit about some of the research that we have done within this sphere to give kind of examples on what other people can also do. Tala and I have a longstanding relationship in genetic counseling. We met when we were students, and we both were doing our graduate school thesis on how gender affirming care might affect cancer genetic counseling appointments and what genetic counselors are seeing with transgender patients in their cancer clinics. And so that started our lovely working relationship. We teamed up as students to do some studies on this, which are shown on the screen. And from there, we've done a bunch of other studies too on how, on some of the knowledge gaps that genetic counselors have for caring for transgender patients. Because when we can find those knowledge gaps, we can start to address them by, doing more studies and things like that. Another recent project that Tola alluded to was a project we did with an MGH student, Antoine Rekovich, on how basically there have been recent genetic studies trying to find a trans gene. So trying to find a gene that impacts someone's gender identity and causes them to be transgender. And basically, there was no study published on how transgender and gender diverse people actually felt about this kind of research. So that's what we worked on with Antoine. He interviewed a bunch of gender diverse people on how they felt about this research. And basically, they felt like it was pathologizing and would likely be contributing to their discrimination. And I use this as an example for how sometimes genetic research is done on and not with communities, and how a lot of genetic research is not done with the best interest of the communities at heart. So I'd encourage future research to really center the voices of the communities that you are doing the research with, so we can not do those harmful types of research projects like finding a transgene. And on a smaller scale, this is some shameless self plugs, but also this is some things you can do on a smaller scale within your own communities. So like Michelle was talking about, we did a webinar specifically on how to care for gender diverse people in cancer, or not in cancer counseling, in any type of genetic counseling, and also how to care for our gender diverse peers, as we know has been a problem recently. So I'd encourage you all to look at that webinar. It's publicly available on NSGC, particularly those who don't feel comfortable talking about gender diversity and are not sure what the needs of transgender people are. This is a good place to start. We've also done a couple of blog posts. Tala did a really great blog post on the DNA exchange about their experience as a minority genetic counselor. I've done a couple on Perspectives by NSGC on how to care for intersex and transgender people and how our clinics are continuing to pathologize these identities. One example of this is in prenatal spheres when we're doing gender reveals with NIPT or with sex chromosomes, how we're really doing the transgender community and the intersex community a disservice. So we offer some changes in language we can all make. Or for folks who don't feel comfortable talking about these things, you can always hire someone, pay someone to come in to talk about it or use pre-existing resources. An example we have is, both Tala and I work at programs for genetic counseling, and we noticed that the education around intersex variations or variations in sex characteristics is incredibly pathologizing. Even just using the framework differences of sex development and disorders of sex development really showcases how the people presenting are not in touch with the community. So we each paid an Interact advocate to come and speak to our program about their experience with their medical journeys. Interact is an organization for by intersex people. And they also have a really great host of videos on intersex care that I'd encourage you to take a look at. So these are just kind of some different ways you can get involved. It can be research, it could be presentations, it could be small articles, or just even sharing some of these types of studies.
And these next few things are just some low-hanging fruit ways for you to start becoming more inclusive. And I always feel funny presenting these because I feel like they're just so baseline, but I know that there's a need to continue reminding people of these things. So anyway, that's my emotional journey with this slide. Anyway, So some of the low-hanging fruit recommendations are to share your pronouns. And then I put the caveat of if you feel safe to do so, mainly because I know for a lot of folks who don't use binary pronouns, so who use non-binary pronouns or who are trans or gender diverse, it can be harder to share your pronouns. And so, I just want to put that caveat in. It took me a while to feel safe and comfortable saying I use she, they. And part of the way I felt more safe is by seeing other people sharing their pronouns. So, that's a really, easy way to, show some support. Hold your coworkers accountable. I think this is especially important if you have gender diverse colleagues, but even if you don't, really just if you hear a microaggression, if you hear someone bringing something up, you being the one to hold your coworker accountable instead of making your queer or gender diverse coworker do that goes a long way. When you're giving presentations or lectures, anything like that, adding issues that are adjacent to your topic. So, if you're talking about cancer risk, bringing up the fact that there's a lack of data on gender affirmation therapy and cancer risk, or bringing up any type of social justice issue or oppression issue that's present in any topic you're talking about, because there always is one. Using inclusive case examples and pictures, so really just making sure you're not only using cis able-bodied white people in your presentations, and incorporating community perspectives. So this goes back to what Kim was talking about and why we felt we needed to bring in someone from Interact, and why it's so important to make sure that you're hearing the community perspective of the topic you're talking about. Another low-hanging fruit is just to use affirming gender inclusive language. So degender medical terms, when you're talking about hormones, don't say female or male hormones, name the specific hormone, same with organs. And I think something also nefarious that happens with our genetic counseling field is we often call each other ladies or women, and there's this assumption that all of us in the field are that gender. And just a reminder that, you actually don't know someone's gender unless they tell you it. And so to not use that type of language when you're sending an email to another genetic counselor or talking to someone. Same goes for the patients, but I just see it a lot more within our field. And then having a plan for dealing with microaggressions. So if this is, a student who's rotating with you or your faculty or anything like that, having a plan for what you're going to do, and really thinking about that and being prepared for that. So again, it's just some low-hanging fruit to call you into action. And, as Kim and I were preparing for this presentation, we wanted to address, the elephant in the room here of how this week was really hard for a lot of gender diverse genetic counselors. And, for those of you who maybe weren't on Twitter, there was, a lot of transphobia we were seeing by genetic counselors on Twitter. And so we wanted to, go through and address some of the ways that, we think you can be an advocate in these types of situations, and some ways that actually didn't feel so great for a lot of folks. So I'll start with a couple. So something that I was seeing that, was something I wanted to bring up was there were some genetic counselors who were validating the ignorance. So, the whole crux of the situation was that there was one genetic counselor who was upset that someone used mixed pronouns. So like me, used she, they pronouns. And, definitely said some transphobic things around that. And one thing I noticed with allies on Twitter who were trying to be supportive was that they would claim that, even though they also didn't understand mixed pronouns, that they wouldn't have said it in that tone, or they wouldn't have been so harsh, or they would have asked the question better. And to me, instead of actually being an ally or an advocate in that situation, it came off as validating the fact that, not knowing how to use mixed pronouns was okay, and was engaging with that transphobia. So, on the flip side, I think one way to have handled the situation was, if you didn't know mixed pronouns in that moment, was to actually look it up, or, look up some resources. And there were some really great resources posted on Twitter about it. So, going into that and educating yourself. Another thing I noticed a lot of were these statements, right? So a lot of the different programs, a lot of places made these statements saying that they were, very, very sorry for what happened, and they were, honoring diversity and wanted to be inclusive. But a lot of these statements didn't have any action behind it. And so on the flip side, I think something that would have been more helpful in that moment was to actually do something, was to advocate in your own space. So instead of just making a statement, can you make some type of training in your space? Can you bring this up and talk to your colleagues? This is a really great place to actually hold coworkers accountable, and really just going into action, as opposed to just making a statement.
Some other things that we saw were people debating aspects of gender diverse people's identities, which is never appropriate, especially when someone's being targeted. So we encourage people to offer support to their gender diverse colleagues and students that you do have a relationship with, and keep the offer about them and not about yourself. Don't ask community members to educate you on their own community. It should not be up to the people who are being oppressed to battle their own oppression. So, a lot of times last week, Tala and I were receiving texts on, oh, but what do mixed pronouns actually mean? Things like that. We should not be putting the burden on the queer community to teach about queer topics. When the queer community does want to talk about these topics and educate on these topics, listen and uplift those voices. Share articles that were created by queer people, share talks that were created by queer people, for example. And the last point on here is we saw a lot of statements that said things like, we value all voices and all types of diversity. And similar to why the statement, all lives matter is problematic versus Black lives matter, we want to center Black voices in that situation. In this situation, we want to center gender diverse people's voices. So by saying we value all diversity, we're undermining the whole issue. And so if you are making statements specifically addressing what's happening, saying that there was transphobia, saying we support our gender diverse colleagues and respect our gender diverse colleagues, etc. And before we pass the buck, we just have one other low hanging fruit slide on things that we can all do structurally to make things better for queer people. Because if queer people are erased from the medical system, not included on EMRs, not included on our intake forms, if we don't even know they exist, we cannot hope to battle healthcare inequity if we don't know what's going on. If queer identities are continually pathologized, we cannot hope to battle these inequities that are happening. So again, I'd encourage students to do research projects related to queer healthcare. And if the student's not queer themselves, to have queer collaborators, just because, again, we want to do research with communities, not just on them. And we want to make sure that the research that is being done in a safe way. It's important for divisions to have training on queer topics, either paying an external trainer, there are lots of those outside of genetic counseling, or using existing resources. Advocating for gender inclusive bathrooms, it's really important that everyone feel like they are safe going to the bathroom. Advocating for having both sex assigned in birth and gender on lab portals, electronic medical systems, genetic testing reports. Advocating for guidelines to be inclusive of folks who are on gender affirming therapies, for example. Making our intake forms have pronouns and live names on them, not just legal names, and also having gender inclusive smart phrases. I only have one smart phrase, and I use the pronoun they in the smart phrase for my things instead of having two smart phrases. And I know a lot of people do that. It'll save you time, and it's also much more inclusive. So I'd encourage you to take a look at your smart phrases and make sure they're inclusive of everyone.
All right, thank you so much, Tala and Kim. At this point, we're going to move on to Tiffany.
Hi, good afternoon. Can you hear me? Perfect. Thank you so much to the Public Health SIG for inviting me to speak today on health equity. And thank you, Michelle, and to Hannah as well. I really appreciate the opportunity. My name is Tiffany Carter, and my pronouns are she and her. I am a middle-aged Black woman, African American, and today I am wearing a light green sweater with pearls that are green and pink. And my background is blurred today, but I'm in my office of cubicles. So thank you again for inviting me. I am the manager. I manage the clinical cancer genetics program at Houston Methodist Sugar Land and West Hospitals in Houston, Texas. I am a graduate of Howard University's DC program, HUU, and I have a BA from Henderson State University in psychology. I train and supervise students for the University of Houston and the Bay Path University's DC students. And I am part of the Susan G. Komen African American Health Equity Initiative, NSGC Cancer SIG Anti-Racism Subcommittee, and I'm a past chair of the NSGC Cultural Competency Subcommittee. So thank you so much again for inviting me today. And you'll notice that at the bottom of my slide, I have the equality, equity, justice, and where we actually often start out, it's definitely not equal. So the reality is that there's a lot of work to be done in this area. And I just want to point out some of those health disparities that are in genetics and with certain ethnicities. So thank you. Next slide. So healthcare disparities we know persist for individuals of color. Oh, go back to me. Thank you. That's okay. Health care disparities persist with individuals of color and with individuals who have lower incomes. And so there's a study that was done by Chapman and Davis in 2020 in the Journal of Internal Medicine that showed that low-income patients and individuals of color are less likely to receive a diagnosis when they go into the doctor. They're less likely to receive genetic testing or be offered genetic testing. They're also less likely to receive a genetic referral. And so there's a lot of work and advocacy that we can do for that. And then they're less likely to be even asked about their family history. So to even have that information analyzed and determine if they would potentially meet criteria for genetic testing or be referred to a genetic counselor. So these are definitely areas where genetic counselors can advocate for their patients. Next slide. All right, and so we know also from the Chapman study that there are, and from other studies that have been published, higher rates of variance of uncertain significance in African Americans and individuals of Asian descent, as well as, I'm going to touch on polygenic risk scores briefly. But in the Chapman study, among the ethnic minorities referred for genetic testing, they found that about 11.1% of them who had a family history of breast and ovarian cancer were found to have a variant of uncertain significance. And of those non-Hispanic African Americans had one of the highest rates, which was 21.8%. Asian Americans had 23.9% VUS rate as compared to non-Hispanic whites who had 9.4% and 9.4% for each non-Hispanic whites and Hispanic and individuals of Hispanic this is an area where our labs can help hopefully try to bring the variant of unknown significance rate down so that we can have better knowledge of what these variants are doing in certain populations. And we can give patients more information and help them make better decisions about their health. In addition, polygenic risk scores have also contributed to healthcare disparities because often, or in the past, they weren't offered to the ethnic diverse populations, and they were also not available. And even now that they're being offered at some labs, they're not performing very well. And so we just need to try to include more diverse populations in these GWAS studies so that we can determine better risk scores and help with prevention and screening especially for cancer and breast and ovarian cancer and other types of cancers. Next slide. And so we also know that in a study that was recently published that looked at the population-based genes in breast cancer, they found that there's an increased risk for variants detected in 5% of women with breast cancer compared to 1.6% of women never diagnosed. So perhaps we need to be offering genetic testing more widely for cancer-related conditions. And then in the study, they found that there was an increasing number of variants found in perhaps genes that we would not expect, like BARD1, RAD51C, RAD51D, or found quite frequently in African-American women with breast cancer. And so again, we need to advocate for larger panels that include some of these genes that we may not expect to have higher rates of pathogenic variants or likely pathogenic variants. And these genes are also associated with an increased risk for triple negative breast cancer, which we know is most aggressive. And many African-American women are often diagnosed with. Next slide. And so I included this slide because this is part of really the healthcare disparities that we see that the American Cancer Society and the Association of Community Cancer Centers has been highlighting in the last year or two. And so we know that African-American women overall have a higher chance, about a 40% higher chance of dying from breast cancer than Caucasian women. The death rate for young African-American women diagnosed with breast cancer is twice that of young white women. This is at ages 49 or younger. And African-American women are most likely to be diagnosed with breast cancer at later stages. So they're getting to the hospitals at later ages, at later points in their cancer diagnoses. And we can certainly do better with that. African-American women are also more likely to have more aggressive disease, as I stated earlier in the previous slide. And we can do better with including minorities in clinical trials. We know that minorities only represent about 10 to 15% of breast cancer clinical trials. So we need to build trust in the community and make partnerships with community organizations who serve individuals of color, and so that we can identify individuals who would fit in some of these studies. The picture off to the right is a article that was published in the Association of Community Cancers. And this is Tammy. She actually started a advocacy program when she was diagnosed with breast cancer in her 40s. And she didn't have the proper support. She was looking for information, and at that time, she was not able to she was not able to find the kind of support and education that she needed based on her diagnosis. And so Carrie's Touch is an advocacy group out of Los Angeles supporting Black women with breast cancer. So there are some great organizations also that we can refer our patients to as well, but we have to be knowledgeable of them. And in this picture, you'll notice that about half of her face is blacked out. It's shadowed, and that's because of this statistic that of 40%, there's a 40% higher chance of African American women dying from breast cancer than Caucasian women. And so it's a really powerful picture that I wanted to include. Next slide. And so on this, I wanted to also include some data on African American men and metastatic prostate cancer. This study looked at pathogenic variants of uncertain significance and likely pathogenic variants. And it found that pathogenic variants and likely pathogenic variants didn't vary by race. However, BRCA1 pathogenic variants were most common in African American men, and pathogenic and likely pathogenic variants in non-BRCA DNA repair genes were less likely to be encountered in African American men in this study. But family history associated with genetic testing results was associated with Caucasian and men only, and not with African American men. So family history is definitely a great tool, and we know that, but it's not always a tool that we can utilize to determine if genetic testing is appropriate or not. And so we know metastatic prostate cancer is as part of the NCCN guidelines. Men do qualify for genetic testing based on having metastatic disease. So we need to be offering that to our African American men as well as other ethnic minorities, to make sure that we can offer them the best treatment options and information for their family members. Next slide. And so the call to action is to lend your voice for change. We know that not family history is not the only thing that determines whether individuals will be qualified for genetic testing, and even if will even be offered genetic testing. And so there are social constructs that we know influence that, where individuals live, their access to providers, access to oncologists, whether they have health insurance or not, whether they have transportation to appointments. There are so many things that influence whether individuals will be able to be cared for once they are diagnosed. And so educate your community, especially in communities of color, and advocate for patients for referrals to genetic counseling. One of the things that I do in my position is I attend a lot of tumor boards, and I make sure that those patients that come up that have not been referred to genetic counseling, and they should be, I speak about that. And I make sure that they do get referred to me, because it's not just important for them, but it's important for their family members. So you can do that as well. I also talk to a lot of community organizations to educate them about genetics and genetic testing. You have a voice, use it. Interpret results for individuals and their family members in the context of their family history. Encourage sharing information in families. A lot of families, they don't share their family history, and so individuals don't know what it is. But encourage them to share their diagnoses, encourage them to look out for one another. Encourage risk assessment as well. This can help with getting individuals diagnosed at earlier ages, where their cancers are most treatable and most curable. And so if they have their risk assessment done and they know that they are potentially at higher risk, they can be screened a lot earlier, and hopefully we will be able to, if something does come up, treat them better. Dispel myths and fears about genetic testing. So educate colleagues and providers. A lot of providers don't order larger panels that might include some of these genes, like RAD51C, BARD1. So we need to help them along a little bit. And educate them about some of these studies that we know are available. Also, patients often think that genetic testing is unaffordable and inaccessible, and it's much more affordable now than it used to be. And so that's something we can also talk to communities about and patients about. Talk with genetic testing laboratories about being more equitable with their PRS scores, VUS data, and sponsoring free testing and having free family studies for family members as well. It makes a difference. Build your trust in the community. Again, partner with organizations and institutions to help promote and advocate for clinical trial participation for individuals of color. Thank you.
Thank you, Tiffany. Building off of Tiffany's last point, I'm very excited to introduce Decca Farah. She is a family advocate leader in Minnesota, and it is so important for us to have family advocates at the table in these discussions about health equity. So Decca is the mother of a son with multiple disabilities, including autism and ADHD. And during the pandemic, she's advocated on behalf of students with disabilities to the governor of Minnesota. So she's a very well-experienced leader in the community. So take it away, Decca.
Thank you so much for having me here. I'm just going to do my image description. I'm a brown woman. I am wearing a black scarf with some flowers on it. I am wearing a white top, and my background is a blank or a kind of beige wall. I'm just sitting in front of the computer. So thank you so much for having me here. As Michelle said, I am, the way that I kind of listed my profile here is how I like to think of myself. I think my greatest achievement in life is being a parent. And that's really where my passion is. I am a registered dietitian by training. I am a parent advocate, disability advocate. I like to call myself a baby advocate because I'm still learning. I'm always learning. And my profession is really about to change specifically for this topic that we are talking about today, which is health equity. I went back to school to become a provider because I was seeing the health equities in my life and the lives of the people that I loved and how that kind of affected their short-term and long-term health, both physically, emotionally, and mentally. And so that's the student part of me. And the way I got interested in genetic counseling is one of the training programs that I had completed recently had it had different providers that took part in the training program. And I had never actually had that interface with genetics and genetic counseling prior to that training program. And I think that's really important. I think Tiffany was talking about how, there is a myth about genetic counseling and genetic testing being inaccessible and unaffordable. And in my community, I'm of Somali descent from East Africa. That is definitely what's out there and the thought out there. And I just took some notes. So I'm just looking at. So it's very important to dispel the myths, like she said, and the fears about genetic testing, because it's quite alive in the immigrant communities, and it's actually, I'm a little bit saddened because of the importance of genetic counseling can have. I mean, back home, I remembered how, for example, if a person was they were never diagnosed with a certain cancer, or breast cancer, it was always, it just happened, or they died of, something happened to their breast and that's how they died. Now in this country, we have all of these different fields and these different technologies, and we can kind of use that to, in essence, really save a life. But the community I come from, that is not even in the radar. That's not talked about. That's not something that is even in existence. And so that's why I'm really excited that I'm here, because I'm still learning, to learn from everyone on the panel and everyone else on the webinar, to bring this information back to my community, of why this is a topic that we should all be talking about and be aware of.
Hey, thank you so much, Decca. So I wanted to get on a soapbox for just a quick sec. So Decca and I both had our schooling in Minnesota at different times, so we haven't met, but both of us were LEND fellows. And for any genetic counselor or genetic counseling student who has the opportunity at some point to participate in the LEND program, it's an interdisciplinary program. It focuses on issues for children and families that are affected by neurodevelopmental disorders. But it really gives a 360-degree view of all the services and agencies and issues that families have to interact with. And those issues also come into play for the queer community, for communities of color. And yeah, the LEND program adds so much more knowledge and understanding of our patients of any backgrounds. So I just want to advocate for that program. Also, I'm really happy to hear all of our panelists talking about community. The word population has really started to get under my skin because it sounds so technical when we're talking about human beings and relationships. And so I've begun transitioning to using the word community instead of population. So anyway, just my random thoughts. So are there any questions for our panelists? I know we're running a little bit short on time, but yeah, if anyone has questions.
Sorry, Michelle, while we wait for questions, I do want to echo the emphasis on community, because that's something our public health SIG is really trying to emphasize. In the same way population seems technical, I think it also feels really inaccessible. So we are hoping that by listening to everyone today, you do see that it's not about attacking this big world that's bigger than you. It's about, really belonging to something and advocating for those people. And I think one thing we did want to touch on is allyship at some point. So maybe we get into that question, because you don't always have to belong to the community, but you should always try to join respectfully. But yeah, I'll just put in my plug. And sorry, everyone, I was late. I'm one of the co-chairs for the Public Health Genomics SIG. I'm Hannah, I go by she, her. I think we have been doing physical descriptions. I am a mixed woman, earlier career. I have brown hair, I have a blurry background right now and a dark shirt on. But yeah, thank you all for joining us.
Thanks for joining, Hannah. I'll also take the opportunity to introduce myself. I'm the other Public Health SIG Genomics co-chair. And you were talking with Michelle, who was our co-sponsor. She was the one who was moderating, and she leads the MGPN, which I think she takes for granted not everyone knows what that is. It's the Minority Genetics Professionals Network, which has done a lot of work at connecting and kind of helping to advocate within the community. So we were really happy to get to sponsor with her for this webinar. And I am Afifa Hamilton. I am also she, her. I'm in my early 30s. I'm a genetic counselor. I am an Arab American woman, and I'm sitting in my home office with a blurred background, which is a cool thing I didn't know Zoom could do until recently, and I really love it. And I'm wearing an orange shirt with a black sweater.
Thanks, Afifa. We'll wait for questions to come in. And Michelle, I don't know if you have a better way of summarizing what I'm about to say, but I think just for the sake of time, we'll take creative liberties and kind of meshing all of the questions we planned kind of together, and just ask the panelists if they could speak about how you can get involved with these communities that we've been talking about. And as I just mentioned a few seconds ago, thinking about allyship, because I think that's something that's come up to us a lot in preparing for today's panel. Not everyone belongs to groups that they want to help. And I think you've done a fabulous job of talking about the communities that you identify with and belong to. And I'm wondering how you speak to people that are coming to you, wanting to know how they can approach the communities that you belong to and work with them in a genuine way, with that emphasis on genuineness, because I think that's, we've all recognized as kind of the underlying current that's so important. And Michelle, feel free to add to my wordsmithing.
Well, I think it's just important to put yourself out there, to let people know that you care about a topic, and that you're willing to use your voice to educate, to work with individuals, and to help them in whatever way that you can. So I think it's about, some of us are a little bit shy, and a little bit afraid to step out a little bit and put ourselves in a position to be able to help and advocate. And so just letting individuals know that you really do care, and that this is a topic that you want to help to dispel disparities for. Even if you're not a part of that community, people recognize and they want you to help them. Everybody needs help at some point. And so people are typically open to that, and just knowing that you want to partner with them in helping their lives become better.
And also remembering to open with asking what the needs are, not just coming in with your ideas of what the needs may be, or, here's my plan to help you. Ask what the needs are first.
Something I think is really important to start is just self-education, because I think it actually can be really harmful to suggest you're an ally if you actually don't know what like a community is. I think a lot about that with the queer community, people who wear a rainbow flag pin. If you're not actually supportive of the community, for example, you should not wear that pin because it'll make people trust you. And I think about that with programs pushing for diversity in their curriculums. Do they have the resources to support their diverse students? So a lot of it, I think, starts with self-education, showing that you are an ally, especially for the queer community. You know, if you are an ally wearing a rainbow pin, showing that you introduce yourself with pronouns. There's some easy ways to show that you're an ally, but being a LGBT provider is far beyond just knowing pronouns and knowing what gender is. We need to know about the actual care needs of these communities too. So that's my soapbox.
I think another thing folks can do as allies is uplift the voices of other people. So uplift folks in the community who are doing that work, like whether that be, you know, inviting them to come speak as long as it's paid. That's my soapbox, which I won't get on, but, you know, bringing people in and trying to amplify their work and spread their work as opposed to reinventing the wheel. So not like redoing what they did, or like Michelle said, assuming what somebody needs, but, you know, taking their work and sharing it and promoting it.
One thing I was going to add, this is Decca, just kind of to piggyback off of what Tala said, is that also kind of giving your time to the younger generations. I think many minority groups are really underrepresented in a lot of healthcare fields, including my own in nutrition and dietetics. And one suggestion that has helped me to improve like the representation of diversity in healthcare fields is to really get involved in exposing these healthcare fields to the younger generation. So if you can volunteer your time, like for example, I became a dietitian not because I saw a lot of dietitians that looked like me, but because my aunt was actually educated in the West. And so she became a dietitian. And by that, that's kind of how I knew that field actually existed. So that's one way of just making sure that not only are you inviting and lifting up the voices of the different communities, but also using your voice and your time to give back to the generation that's going to be coming up, so that they have that exposure to the different healthcare fields.
I'll echo some of that by saying I don't think people realize how much of this work is like grassroots. Like it very much is like dependent on relationships and like single voices and gathering momentum. Because I think people like discredit the amount that they can do as like an individual and things, and by like changing the work culture that they're at. So I just want to call that out because I think I'm getting lots of nods. It feels like that's been like a similar shared experience with all of us, that like you can get the ball rolling quite impactfully as a single person, bringing others in.
Another suggestion that occurred to me during the course of this webinar is reach out to your Department of Health. You know, they may be working with underserved communities that they could help direct you to if you don't know where to start. And not all departments of health are good in that, or are active in that way. But if they are, that could, you know, they could point you to different organizations. Also knowing that, you know, as genetic counselors, we're very familiar with advocacy organizations around specific conditions, but there are also organizations, Family Voices, Family to Family. There are family advocacy organizations for families with all sorts of disabilities. And helping, I'm thinking from a pediatric lens, but helping with transition to adulthood, thinking about, you know, if there's advocacy needed in the school for services, making sure that people are getting all the services that they need from a medical side. So those general family advocacy organizations are very important partners.
We have just hit 4:30, and we did have a few questions in the Q&A chat, but if there's any other questions that you have that you're unable to ask, please feel free to email us. Hannah's email address was at the very beginning of the slideshow, and you can also email the Public Health SIG email address, which is nsgc.pubhlthsig@gmail.com, and we will forward any of your requests to the panelists, any of your questions, and collect those answers and get back to you since we don't have longer time for the Q&A. And yes, Hannah and Michelle both put their email addresses over there in the chat for you guys. And the webinar was recorded, and we will be posting it on YouTube, and you will get a link that will be sent to you with the Zoom like thank you like email 24 hours after the webinar closes. And do not forget that if you are going for CEUs, you also need to fill out the survey that will come to you via email in that same thank you email. And it will appear to come from like Zoom or the NSGC SIG leader's email address, but that's important if you want to claim CEUs. And Hannah, if you want to give just a 2-second into our last webinar of the series.
Oh yeah, so so this is our third of 4. We are planning hopefully in December to have kind of a wrap-up session. I think throughout the series, we've touched a lot on like the need to really look at what we're doing as genetic counselors and be really thoughtful about, what are genetic counselors doing? How do we evaluate what we're doing? How do we know that people are accessing care? So that's all going to hopefully be brought together in our last webinar of the series, focusing on evaluating practice and accountability and things along that vein. In collaboration with the National Coordinating Center of Regional Genetics Networks that thinks a lot about evaluation, and hopefully some practicing genetic counselors that have thought in this area before on how to really just be thoughtful about practice. In general, we've been advertising these things through our Twitter, and I don't know the handle off the top of my head, but you can probably look for it. That's our best way of trying to reach a broad audience. We have also been trying to post to the NSGC community board, but recognize that that's pretty restrictive to you being a member and having signed up for updates. So hopefully the Twitter helps you find things easier. I think that's my last wrap up. I don't know if any of the panelists have any final thoughts that they haven't had a chance to say, but please feel free. It seems like we have quite a few lingering attendees.
I just want to say real quick, sometimes providers don't order enough genes and they're afraid to do that. I personally had to talk to one of my providers before about ordering larger gene panels that are more inclusive of genes that are not just, B or CA. And so please talk with your providers about doing that. They're often open to expanding. They just need to feel comfortable knowing that you're there to help them if something does come up.
Thanks, Tiffany.
Becca, did you have anything that you wanted to add before we close?
I guess the only other thing that I wanted to say is that communities, immigrant communities are really open to learning. I would say, I can put my information on, share it with everyone, but just asking questions. I think one of the questions was kind of how to what have I experienced with educating a provider or whatnot. I think it's just important to recognize when you're seeing a person, a client or a patient, that the person that is in front of you, I think it might have been Tiffany that was talking about this, but they might have had a really, really rough day, and just making sure that just don't be, don't have any fear of asking questions. I always say, don't assume, just ask as many questions as you can, because if we don't ask questions, then we don't learn, and learning goes, both ways.
Worst action is inaction, seems to be the theme. I think, unless Tyler or Kim, if you have anything else to add as a final wrap up, I think we'll end. Okay, great. Thank you everyone for attending and those that stayed on a little late. Yeah, I hope we see you at our next one. And thanks everyone to the panelists. It's good to see you all again.
Thank you.